Thank you for viewing the presentation. During this lecture, I will review fetal cardiac arrhythmias and the echo methods we use to detect and diagnose them effectively. I'll also highlight the proper techniques to provide cleaner, more reliable tracings, which facilitates accurate diagnosis and provides optimal measurements. I just wanted to review some normal values for fetal heart rhythm. So normal heart rates for the fetus will be between 120 and 170 beats per minute. Below 120 beats per minute is considered bradycardia, and above 170 beats per minute is considered tachycardia. And you can see how these values have change over the gestation, but typically between the age of 20 weeks and the end of pregnancy, those values are pretty flat, and so this range is appropriate for the age range that you will be scanning these fetuses. A normal mechanical PR interval is going to be less than 150 milliseconds, and you can see these values also change over the course of the pregnancy, but they should never exceed 150 milliseconds in a normal situation. And then the A to A and V to V intervals should be constant and consistent, and those are rate dependent, but they should be measuring identical in a normal situation. I also think it's important to review the cardiac conduction system as a review point for this presentation. So we can see the cardiac conduction system here on this diagram, and you can see the SA node and the AV node, and then the bundle of His and the bundle branches with Purkinje fibers. First part of cardiac conduction starts at the SA node, where the impulses pass to the AV node, and this represents the P wave on the ECG. Now, the next stage is going to be a pause in the conduction at the AV node, and at this point the atria are contracting. So the physical contraction of the atria happens during this PR interval, and then after that pause or that delay of about 120 milliseconds, that impulse passes quickly through the bundle of His and the bundle branches here and throughout the Purkinje fibers, and that represents the rapid depolarization and contraction during the ST segment of the ventricles. Now, shortly after that, there is ventricular repolarization, and then the next cardiac cycle starts. Now, there are methods to directly evaluate the fetal heart rhythm using fetal ECG or magnetocardiography, shown here on the right. This is fetal ECG, where you place these electrodes on the maternal abdomen, and then a very specialized ECG system can pull out this kind of signal, where you have the maternal heart rhythm and also the fetal heart rhythm superimposed on this tracing. And then this goes through a filtering system in the ECG machine, where a lot of math happens and you get this scrubbed out, filtered out signal of the fetal heart rhythm, which still is not very clean and is not legible enough to evaluate anything besides the fact that this heart rhythm is a regular rhythm. So for this reason, we, during our anatomical scans, use these echo-based techniques to evaluate or try to evaluate the fetal heart rhythm using M mode to evaluate mechanical events, and then Doppler, pulse Doppler to evaluate flow events, which essentially are mechanical events. And you can see here on this side, we have an anatomical M mode, where we are transecting different segments of the heart, an atrium and a ventricle, and this gives us a nice tracing to evaluate one-to-one conduction here. Doppler can tell us flow velocities and direction of flow, can also show us timing of events as well, measuring intervals between these very sharply displayed waveforms. Okay, so let's talk about optimizing your images for this assessment. And so for M mode, you want to make sure that you're using a 4-chamber view, and you want the heart to fill the zoom box. You're going to zoom in on the heart to get the tightest picture around the heart so that you can get the best M mode tracing. It's best to transect the right atrium and the left ventricle. And so if you can get the heart in an angle where you can transect the right atrial free wall and the left ventricular free wall, this will give you the optimal M mode tracing in order to really accurately see those parts of the heart contracting. And then you can use anatomical M mode if you need to get that angle aligned where you can't get the fetus in a position where you can transect them without using anatomical M mode. For Doppler, you want to increase the sample volume just slightly when you're doing the mitral inflow-outflow or the SVC aorta. This allows you to get both of those flows within that sample and tracing those flows nicely and cleanly. But beware, if you increase more than 5 millimeters, you may pick up some contaminating flows that are adjacent, as shown here. And so a good example would be the pulmonary venous flow, left pulmonary venous flow, and the 4-chamber view. You can accidentally pick up some descending aortic chatter on the baseline if you're not careful. And that brings you to the increasing of baseline filter. You want to make sure that you increase that filter so that you filter out some of those contaminating flows that are in the periphery. The use of M mode is one of the simplest modalities to use evaluating the fetal heart rhythm, and you can see here we have transected the right atrium and the left ventricle, and the right atrium here is depicted by these waves on the top of the tracing, and you can clearly see where the yellow arrow is pointing. That is the atrial pulsation here, and then on the bottom, the left ventricular free wall is this red arrow here, and it's good for most arrhythmias. You can see the deflections quite nicely here, and you can make out what the atrial and ventricular activity are, but it's difficult to measure intervals. And so as you can see the AV intervals, but it's hard to measure exact timing of events accurately. Now, this first Doppler method is called the left ventricular inflow-outflow method. And what this is pulse wave Doppler in this 4-chamber view, really a 5-chamber view, with a mitral valve inflow and aortic valve outflow. We place this widened sample volume in the middle of those flows, and it's fairly easy to obtain in this 4-chamber view as long as the flows are aligned properly. It's very good to measure intervals. As you can see, this is the mitral valve inflow pattern here on the bottom with biphasic E and A waves, and then you have the ventricular systole with this aortic outflow here. And what we've measured here is the mechanical PR interval. Nice sharp region here at the beginning of the A wave to the onset of the V wave, and that is a measurement of the mechanical PR. Another method is the pulmonary vein, pulmonary artery Doppler method. And we see here in this sort of upswept 4-chamber view, the right pulmonary vein here. You can actually see the left pulmonary vein here, but we want to avoid this pulmonary vein due to possible contamination from this descending aortic signal here. And so the right pulmonary vein here is where we would place this slightly widened sample volume of our pulse Doppler. And you can see the red flash in there. That's the pulmonary artery, and that's the pulmonary vein, the blue there. And when we get this tracing, we see on the bottom the S and D waves of the pulmonary venous tracing. And here is the A wave, this little notch that passes above the baseline in this tracing. And then the V wave is this sharp little upstroke here. And this is the pulmonary artery flow signal. And so here we've measured the mechanical PR interval again at the onset of the A wave to the onset of the V wave. This is probably one of the better methods to measure intervals, but it's not good for all arrhythmias. The SVC aorta pulse wave Doppler is probably the most accurate and measurable method to look at fetal rhythm. And so we see here, this is a sagittal view showing the SVC coming into the right atrium here. And this red flash is the ascending aorta. Again, this is from the back of the fetus. We see here the spine. And this can be obtained from the front of the fetus in a sagittal format, as long as these flows are aligned with the plane of inclination. As shown here, we have our sample volume slightly widened and covering both of these flows within that sample. And then when we see the tracing, we can get both the SVC as it's going down on the screen. We see it below here. This is the S wave and the D wave. And then you see the slight reversal with the A wave here, the A kick, and then the V wave here, the aortic flow going out of the aorta above the baseline. Nice sharp delineation of the flows and nice measurements for the timing of events. Here is the mechanical PR interval, and this is good for all arrhythmias. Premature atrial contractions are the most common type of fetal arrhythmia, happening in about 90% of all fetal arrhythmia cases. These are usually detected beyond or later than 30 weeks in gestation, late in the third trimester, and we commonly see this in association with atrial septal aneurysm, with a hypermobile atrial septum. There are two different types, conducted and non-conducted, and we'll go over what that means a little bit later in the presentation. These are usually benign, although supraventricular tachycardia can happen in 2 to 5% of these, and it can be associated with structural heart disease, most commonly in Ebstein's and tricuspid valve dysplasia, where you have significant atrial enlargement, and also tumors or masses within the heart. And so here we see a 4-chamber view with slight right heart enlargement, and noticeably we can see this hypermobile aneurysmal atrial septal flap into the left atrium here, and these are PACs, looks like in bigeminy. So here's an M mode for that same case. We see here at the top of the screen, this part of the M mode is transecting the left atrium, and then you have the right ventricle here, and so you have left atrium, right ventricle, and you can see going across, these are the A waves, these are the atrial contractions, and the A to A intervals are all normal, as well as the V to V intervals, so A, V, all the way across until you get to this point. The A to A interval is shortened. This is a premature atrial contraction, and this premature atrial contraction has been conducted to the ventricles, and so you see in coordination with this premature atrial contraction, we have a premature ventricular ejection as well, and so this V to V interval is shortened and matches this A to A interval. And then there's a compensatory pause here with the next sinus beat, AV, and then the sinus rhythm picks back up, but then you have another premature atrial contraction here. And so this series of 2 premature atrial contractions which have been conducted and this M mode is a very good example of how these premature atrial contractions can be conducted in some of these cases. Mitral valve inflow Doppler here, we can see EA, and the V waves on the bottom. And again, this is in a conducted PAC, and so you have the A to A intervals are regular here all the way across. This A to A interval is shortened because this is a premature atrial contraction. You do not have the E wave because this is an A wave, and then you have a small little V wave that was conducted as a result of this premature atrial contraction. And then the mitral valve inflow and aortic valve outflow, LV inflow outflow view here, 5-chamber view with this slightly widened sample volume. You can see here the EA here, this is the A wave. Again, these are all regular conducted PAC with this small V wave. So what happens when the premature atrial contraction is non-conducted? And so in this 4-chamber view, you see right atrium here at the bottom, left ventricular free wall here at the top, left ventricular free wall, right atrium here. We see the A waves are nice and regular. Premature atrial contraction occurs here. Now, we can see the A to V intervals are all normal, but then once you get this premature atrial contraction here, it happens simultaneously during this V wave, and then the ventricular conduction is dropped and lost. And so you have this pause here until the next sinus A to V happens, A to V. And so this is an example of a non-conducted premature atrial contraction. Now the same thing happens here with this mitral valve inflow, aortic valve outflow. We see the A to V, A to V, nice normal AA intervals, VV intervals all conducted. Here's the premature atrial contraction. This interval is slightly shorter than the others, and you have no V wave happening here. This is a non-conducted premature atrial contraction. Same thing here with this pulmonary valve outflow. You can see that there is not a ventricular contraction, no ejection out of the pulmonary valve after this premature atrial contraction happens. Premature ventricular contractions, or PVCs, are much less common than atrial ectopy. They're not easily distinguishable from junctional ectopy or junctional premature contractions. It's difficult to distinguish between the two. And these are not usually benign. They can be associated with myocarditis or type of cardiomyopathy, tumors, for example, rhabdomyomas, and I have a case later in the presentation that shows that, and also long QT syndrome can also be a cause of premature ventricular contractions. Here's a nice tracing M mode of atrial activity on the bottom, ventricular activity on the top, and so you can see the A to A and V to V intervals are all normal, and then here is a premature ventricular contraction, which happens slightly after this atrial contraction here, but these are all, the A to A intervals are all normal, including this one and this one here. This is a premature ventricular contraction, and then a compensatory pause that we have until the next sinus beat, but this ventricular contraction does not correspond with this atrial contraction, and so these are isolated PVCs shown. Another really good tracing here, atrial activity on the top. You can see that A to A intervals are all normal, except for this break in the MO, but you can see here all of these, including during the premature ventricular contractions, they're all regular, and then this PVC here, we see that this V to V interval is not normal and consistent with the other V to V intervals. PVC here, 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 and here, not corresponding with the atrial activity. Isolated PVCs. Tachyarrhythmias, there are two main types of tachycardia. We have supraventricular tachycardia and ventricular tachycardia, but in general, any heart rhythm that goes above 170 beats per minute is considered a type of tachycardia. AV reentry tachycardia, or AV NRT, is the most common type of SVT, supraventricular tachycardia, followed by sinus tachycardia. Junctional ectopic tachycardia is quite rare. Ectopic atrial tachycardia is a secondary only to AV NRT. It's the second most common, followed by sinus tachycardia. And then atrial flutter is when we have A rates that are very high, above 350, typically above 250, 300, sometimes reaching 350 to 500, and I have an example of that, and variable ventricular rates. Ventricular tachycardia is very rare and sometimes can be ominous. Well, you have isolated VT, which can be associated with masses and myocardial disease, and torsades is something that we see associated with long QT syndrome. This is supraventricular tachycardia. We see a four-chamber view here, color compare, and you can see the LV here and the right atrium here. And here we can see an M mode pass through there, one-to-one conduction, ventricles on the top, atria on the bottom, and we can see that the heart rate is at 189 beats per minute, which classifies as supraventricular tachycardia. Now, one thing to note about this is a mitral valve inflow, sort of LV inflow outflow view, a little bit deeper into the ventricle than we typically see, but we're getting the V waves here. And so what you see typically with SVT, the AV and VA intervals, so the the A to V interval, so the onset of the A wave, which is this, to the V wave here, is similar, if not identical, to the V to A interval. But with atrial ectopic tachycardia, the VA interval is much longer than the AV interval. And I don't have an example of that, but just keep in mind that this is the way that you can differentiate the two, SVT and AET. Now this is an example of a more rapid supraventricular tachycardia here, where you can see the ventricles are not functioning very well. The heart is essentially just quivering in this picture, but there's an absence of any significant pericardial effusion, no pleural effusions. And so what we will do is we'll check the rhythm and the rate, and here we can see that the rate is 214 beats per minute. This is an M mode through the LV and RA, and we can see it's 1-to-1 conduction. And when we look, we can see on the DV there are flow reversals, atrial pulsations that transmit all the way back to the UV, and this is indicative of high right atrial filling pressures and high filling pressures in the heart in general. This is most likely a long-standing SVT that's incessant and has been continuous for some time. This is atrial flutter, and you can see a very rapid atrial rate here, almost a quivering of the atrial walls, and a very rapid ventricular rate as well, not quite as rapid as the atrial rate. And so when you look at the M mode, you can see what looks like really almost 2-to-1 the rate of the atrial contractions are almost 2-to-1, maybe even 3-to-1 in some cases. These are the V rates on the bottom. The V to V intervals are longer than the A to A intervals, and when you measure these out, you can see that the V rates are less than half at 200 beats per minute than the A rates. The A rates almost approach 500 beats per minute. And here you have some breaking of that atrial flutter, but a reversion over here. And so it was off and on, but this patient actually responded to antiarrhythmic therapy. Now, ventricular tachycardia is the least common and probably the most serious tachyarrhythmia. And this can be associated with myocardial disease and also can be seen in long QT syndrome. This particular heart has rhabdomyomas, a large one here in the tricuspid valve annulus here, partially blocking inflow, but also some tumor invading the right AV groove and most of the right ventricular free wall, and this is contributing to this ventricular tachycardia. You can see here the left ventricular free wall, part of the septum, is contracting erratically. Look at the M mode, you can see atrial activity on the top, and it is also erratic, but the rate is not quite as fast as these ventricular tachycardic runs here. And you see here there's a run of ventricular tachycardia here, slight pause, and some PVCs, and then another run. And we can see the rates are quite elevated. We see 268 beats per minute, anywhere from 268 to 273, 288 here. Very rapid ventricular rate in this ventricular tachycardia case. This is another case of ventricular tachycardia, and this one looks more sustained. As you can see in this 4-chamber view, just very rapid heart rate. It looks almost 1-to-1, but when you look at the M mode, you can see here on the top is the ventricular rhythm, and you can see the V rate is around 217 beats per minute. And the A rate on the bottom, you can see the atrial wall here depicted down at the bottom, and you can see that this rate is a normal rate at 156 beats per minute. So the ventricular tachycardia is happening at a faster rate than the atrial rate. This particular case is related to fetal long QT syndrome. Let's go over bradyarrhythmias. When we talk about bradycardia, we're talking about heart rates that are less than 120 beats per minute sustained. And sinus bradycardia is one-to-one conduction. This is the most common. This can also be associated with long QT syndrome. We typically will see sinus bradycardia with ventricular arrhythmias and then ventricular tachycardia as in the last case that we just reviewed. Junctional escape rhythm can also be a slower than 120 beats per minute rhythm. Non-conducted PACs and bigeminy, this is one of the most common things that we are referred at our practice with bradycardia from the OB or from the maternal-fetal specialist, and we find that these are just non-conducted PACs and bigeminy. 2-to-1 atrioventricular block is also a type of slower ventricular response or ventricular rhythm. Two P waves to one QRS or two atrial contractions to one ventricular contraction can cause the ventricular rate to be half of a normal heart rate. So, and also complete heart block, the same, where you have complete dissociation of the atrial activity and the ventricular activity, and the ventricular intrinsic rates are much lower than 120 beats per minute. Now, this is a good example of sinus bradycardia with one-to-one conduction in this four-chamber view. This case just happens to be a left atrial isomerism heterotaxy case. You can see here dilated azygous vein. This fetus has interrupted IVC with azygous continuation, but an intact heart. So no atrioventricular septal defect as we commonly see, but some right heart enlargement here. And when you look at the M mode, you can see that it's one-to-one conduction, normal intervals here, AA interval, VV interval, normal AV intervals. It appears on this M mode, but one-to-one conduction all the way across, and we see that the heart rate is 91. A typical, for this case, a typical mitral valve inflow pattern for this slow rate, you have a very long early filling phase, and then in this case, a shortened mechanical PR interval, and we see that it's at 88 milliseconds. And so when we look at the DV, we can see signs of high filling pressures from that shortened mechanical PR. You have atrial reversal here, and you actually have ventricular systole onset before the end of the P wave, the atrial contraction, and so hence the notching on this A wave here. Blocked premature atrial contractions in bigeminy is where you have a conducted sinus beat, and so you have an A to V interval, which is normal, and then a premature atrial contraction, which is not conducted. And so the sinus beat is conducted, the PAC is not conducted, and this goes on in a bigeminal pattern. And the way that you can tell this, this is PACs and not 2-to-1 AV block, which is really the next thing that we're going to look at, is the short to long A to A intervals. And so you have a sinus beat, premature atrial contraction. This is a shorter A to A, and then a long A to A to the next sinus beat, short, long, all the way. And so you see this rhythm is a regular rhythm, and we see this in some cases incessant throughout the whole study. Now this is second degree Mobitz type 2 2-to-1 AV block, and it looks very similar to PACs in a bigeminal pattern, block PACs in bigeminal pattern, where you have a sinus beat that is conducted and you have a QRS complex, and then you have another sinus P wave with no QRS complex. And so this goes on throughout the entire rhythm, where you see what looks like 2-to-1 blocked PAC without conduction, when actually you would look at the A to A intervals and they're all regular and consistent, and you have a conducted sinus beat, and then you have a blocked sinus beat, and then this goes on throughout the whole rhythm. So 2-to-1 Mobitz type 2 AV block. Now, Doppler interrogation of this 2-to-1 AV block confirms that the A to A intervals are all regular, and the conducted A to V here, this conducted beat, shows a very short mechanical PR interval. Third degree, complete atrioventricular block is where you have complete dissociation between the atrial activity and the ventricular activity, and so there's no real normal PR interval. You just have the A waves, the P waves, the atrial rhythm doing its own thing, and the ventricular rhythm doing its own thing in a dissociated fashion. So here you see this how slow the intrinsic ventricular rate is, and you have this echogenic appearing atrial tissue here in both atria. This particular case is a case of Sjogren's syndrome, where you have autoantibodies that have caused this issue with the conduction system. And so the M mode is most helpful in this particular type of fetal arrhythmia, where you can actually see how the atrial activity is completely dissociated from the ventricular activity. You can see here the A to A intervals are all normal and regular, as well as the ventricular intervals, the V to V intervals. But you can see that there's complete dissociation with the A to V activity. And so nothing really lines up as normal conduction. It's all just completely dissociated. Spectral Doppler is helpful, but not as helpful as M mode. You can see the V to V intervals are all regular, A to A intervals are all regular, but it can be difficult to pick out exactly where some of the A waves happen. Some of them happen during the ventricular contractions, and so you sometimes will not be able to pick up some of those waves. First degree atrioventricular block is where you have prolongation of the PR interval, and in this case we can see the PR intervals exceeding 150 milliseconds, which is the upper limit of what we would normally see in the fetus. When we're looking at the mitral valve inflow in this case, you can see fusion of the E and A waves, and then when you look at the mechanical PR interval from the A wave to the onset of the V wave, the aortic outflow in this case, you can see that it's quite prolonged at 186 milliseconds. And then you can corroborate that with the pulmonary vein, pulmonary artery. Here's the S and D pulmonary venous tracing on the bottom, and this is taken from that right pulmonary vein. And you can see the onset of the V wave here, and when you measure that, it matches up with the 186 milliseconds that we saw from the mitral valve inflow, aortic outflow. Now this is the SVC aortic tracing, and you can see clearly that the V wave, the onset of the ventricular systole, is happening during early filling phase, so the diastolic filling phase of the SVC inflow here, and so that causes this to be a monophasic sort of A wave driven inflow of the ventricles. And so this is an extreme case here. This is another SVC aortic tracing. In this case, we see a prolonged PR interval of 255 milliseconds, which is quite long. You can see the A wave here nice and clearly shown, and we see the onset of the A wave until the V wave here. Clearly, this V wave is happening directly on the diastolic early filling phase of the atria. And so this is a very prolonged PR interval. And when you look at the M mode in this case, you can see that the A waves are happening with the previous V waves, and so directly during that time. And so this is the PR interval. This A wave belongs to this V wave, and all the way down the line, you can see just how prolonged these intervals are. Now, I've done these out of sequence simply because this arrhythmia did not classify as a bradycardic arrhythmia, and so this is second degree Mobitz type 1 AV block. We also call this Winkelbach phenomenon. And this is what happens when you have progressive lengthening of the PR interval with a subsequent dropping of the P wave to the ventricles, or non-conduction to the P wave to the ventricles. And so we'll have this progressive lengthening of these P waves here, the A waves, and we see that these are all regular, and you can march this all the way across, and you can see the intervals are all regular, but then you have progressive lengthening here of these PR intervals until you have dropping of the QRS complex here. And so what this looks like in reality, with a 4-chamber view here, you can see that it looks erratic, but it also just looks like normal sinus rhythm with an occasional PAC. But when you evaluate this with M mode, you can clearly see here on the bottom, these are atrial A waves, and you can see that they're all nice and regular. But then when you look at the ventricular activity, it looks like you have some dropped, some gaps between the V waves here. And what's happening is prolongation. Here we have an AV that has a shorter interval, and then you have a longer interval here. And if you trace these out, you can clearly see that the PR interval is lengthening. Even though the A waves are all constant, you can see a dropping for this A wave here. This happens during that V wave, and then there is non-conduction, and then on to the next resetting of that PR interval, and then it lengthens some more, and then drops. And so here we have this activity. And so this is the same case. This is sort of like an SVC aortic tracing, where you have here you have this gap from the previous non-conduction, but you have a short mechanical PR interval here, and you can trace this out. Here's the A wave to the V wave. It lengthens a bit, it lengthens some more, and then non-conduction occurs here. So you have a dropped QRS or a dropped V wave with no ventricular conduction. So in summary, these echo methods for fetal arrhythmias are effective if used in combination. Just remember that you need to optimize your images and obtain clean, artifact-free tracings for accurate measurements. Remember that M mode is the easiest to employ, but you make sure that you have optimal angles to get the best tracings. M mode is also good for determining AV relationships, but it's difficult to accurately measure intervals. And spectral Doppler for the mitral valve and the aortic tracing, it's easy to do, it's good for intervals. Pulmonary vein and pulmonary artery is also easy to obtain. It's very good for mechanical PR intervals, but it's not good for all arrhythmias. And the SVC aortic tracing is quite hard to master, but once you get it, it's very, very good to measure intervals and to evaluate arrhythmias. Once again, thank you so much for viewing my presentation. Please stay tuned for more in the future.